Good morning, everyone. Welcome to the third annual BPREP Patient Forum. My name is Tari King. I am the Chief of the Division of Breast Surgery at Brigham and Women's Hospital and Dana-Farber Cancer Center, and we are delighted to have you here with us this morning. Just a few housekeeping rules as we get started. We have several panelists who are eager to speak with you this morning, and we'll just remind them to have their microphones on mute when they're not talking. You as our attendees are automatically muted, not because we don't want to hear from you, but because we want to keep it a nice, quiet environment for everyone this morning. Please, though, send us your questions using the chat function. We will be monitoring that. We will be trying to answer your questions at the end of each session, but we are also going to be recording them, and we'll be creating some materials to send back out to you after the forum this morning to make sure that we get as much information to you as we can. And yes, we'll be monitoring throughout the session, and we look forward to hearing your questions. So we have put together what we hope is a engaging agenda for you this morning. I'm going to kick it off with a small introduction, and then we have several speakers from our institution who will highlight risk-reducing options, including medications, the role of exercise. We'll break up the morning with a small exercise demo to let you get up and move around a little bit. Then some self-breast exam tips and techniques, some common breast questions and concerns, and then we'll wrap it up with genetic testing, things to consider when you're asked to participate in clinical research, and then finally a small relaxation session at the end to help everyone go out and enjoy the rest of their Saturday morning. So without further ado, I know we have a lot of attendees this morning who maybe have never been to the breast center or maybe never heard of the BPREP program. So I thought I would just start with a little introduction as to who we are, where we are, and the kind of work we do. So at the Brigham and Women's Hospital, we have a comprehensive breast center, and that is where the BPREP program lives. In our comprehensive breast center, we evaluate patients with non-specific or non-cancerous breast complaints, such as breast pain, lumps, nipple discharge. We perform workups for abnormal breast imaging, and we help women understand their biopsy results. We evaluate patients that have suspected or known increased risk of breast cancer, and this includes women that have had biopsies that show what we call high-risk lesions, and we'll talk about them a little bit more this morning as well. And then we evaluate patients who simply want to learn about their breast cancer risk, whether or not they have a family history or not. And we evaluate patients who are seeking additional information about dense breasts. We give recommendations for surveillance and so on. So anybody is welcome to come to the Comprehensive Breast Center and to have their breast cancer risk evaluated. And so this is sort of the picture of what that looks like. So women can come for any number of different reasons. Everybody that comes to our breast center takes standardized risk assessment, either on the laptop in the clinic, or we can email it to you in advance at home. Once you're in the clinic seeing us, we then use all of that information in real time to evaluate a woman's risk of developing breast cancer. And of course, we take care of the problem if there was a problem that the woman came in for. If women are not high risk by our risk assessment tool, then we reassure them and provide them with recommendations to continue their follow-up with their primary care physicians or their OBGYNs. And women who are at high risk, they are invited to stay with us and participate in our BPREP program. And really a big goal of our program here is education. We want women to understand their risk and understand what their options are for managing the risk. So just to give you a brief intro then, so we started this program in the spring of 2017. I have to give a shout out to Susan G. Komen for the Cure. I was able to start this program with a scholar's grant from Komen, and so we thank them very much for their support. And this is a snapshot of the first year of the program. So in the first year, we evaluated just over 1,200 women without a personal history of breast cancer who completed our intake survey. And about 70% of those women actually did meet one of our criteria for being at high risk. About 330 of those women knew they were at high risk because they'd had a biopsy that showed a high risk lesion. But we actually evaluated and educated about 550 women regarding their breast cancer risk in this first year of the clinic. So these women did not realize that they were at increased risk of breast cancer. And this was the impact that our program had within the first year. So what are the criteria then for participating in our program? Well, we provide ongoing follow-up, again, for women either with a family history that's suggestive of or a known genetic predisposition, a documented genetic mutation, or what we call a variant of uncertain significance. And of course, these women we care for in collaboration with our genetics partners at the Dana-Farber Cancer Institute. Women with a personal history of radiation to the chest at a young age. These women are also at increased risk for developing breast cancer. Again, personal history of a biopsy showing a high-risk lesion. And then we use risk prediction models to estimate women's 5-year or lifetime risk of breast cancer. And those women, again, that are estimated to be at high risk based on these models are welcome to participate, and women with extremely dense breast tissue. So our team is a very multidisciplinary and comprehensive team in the Breast Center and in the BPREP program. You're going to hear again from several of our members this morning, but I also want to highlight for you some people that you won't be hearing from this morning, but that are certainly critical to the success of our program. Mary Beth Hans is our PA, who is the clinical director of the BPREP program, has over 20 years of experience in evaluating women with breast disease. Mary Knos-Grachin, also a senior NP in our program, again, over 20 years of experience evaluating women with breast disease. And Susie Tsai is a PA who has a lot of experience as a PA, but has just joined our program. And so they are really the core team in the Breast Center. They are there every day helping us evaluate all of our patients. You'll hear this morning from Brittany Bishkovsky and Judy Garber, two medical oncologists who are collaborators from the Dana-Farber Clinical Genetics Group, as well as Rochelle Scheib, also a medical oncologist working in the Dana-Farber Genetics Group. Lydia Pace is a primary care physician who works with us because she has a special interest in breast disease. And then Eileen Joyce is our social worker. Again, you'll hear from her later this morning. And then this team is supported by 5 breast surgeons that do spend some time in the Breast Center. Our goal is to get information out to you, our patients, our audience. And so we do put out a newsletter at least once a year, sharing information about what's going on in the clinic, the research activities, tips and tricks. And here I'm showing you, we do have highlights from our BPREP program last year online on our website. And we will be, as you know, we're recording this session this morning. We plan to share this year's session with you on our website as soon as we can as well. I just want to draw your attention to one really, I think, powerful video that is on our website from last year. This is Mill Pierce. Mill was one of our first patients in the BPREP program. And this is a picture of her where she's consenting for an exercise trial that we were running at the time. Mill is a real champion. She really embraced the exercise research study that she was participating in. And she gave a really wonderful talk at the forum last year, again, which is available on the website. So let's start a little bit with why we're here today. So what does it mean to be at increased risk? Well, this means that your chance of developing breast cancer is higher than the average woman's chance of developing breast cancer. And we all know from the news and the media that 1 in 8 women, or 12% of women, will develop breast cancer in their lifetime. So this little picture has 100 gray women and 12 women are pink. So 12 out of 100 women, that's the average risk for developing breast cancer. So what is cancer? In general, cancer is a group of diseases that are characterized by uncontrolled growth and spread of abnormal cells. So when we think about this in the context of breast cancer, the breast tissue is made up of milk glands and milk ducts, and all breast cancers actually begin inside the wall of the milk duct. So on The panel on the far left is a normal milk duct that's just lined by a single row of cells, and the center, the lumen, is open. The earliest form of breast cancer is what we call duct carcinoma in situ, or pre-invasive, and that's when these cancer cells stay inside the lumen of the milk duct. They are completely confined inside the duct. And invasive cancer is when those cells start to break through the wall of the duct and get out into the fatty tissue of the breast. So we know that there are many risk factors for breast cancer. When you come into our clinic or when you go to your physicians, they ask you things about your reproductive history. We know that obesity, we know that alcohol consumption and genetic factors are also associated with risk for breast cancer. And again, we're going to talk more about these things this morning. Our goal is to try to estimate risk for women. What is an individual woman's risk? And for this, we use risk prediction models. And these models help us to identify women at increased risk, women that may benefit from interventions such as chemoprevention, women that may be good candidates for our research studies, and women that may need increased surveillance in their screening. And this is sort of the ideal model here. The goal is to identify women at all different levels of risk, those that are low risk that maybe don't need as much screening, as well as those that are at high risk that maybe do need more screening. And so there have been many models that have evolved over time trying to incorporate new information as it comes out to try to understand breast cancer risk. And when we look at the performance of these models, there's two measures of how well a model does. There's the calibration and the discrimination. The calibration tells us how well a model performs in a study population. So for example, of 100 patients like you, 20 will develop breast cancer. The model tells us what will happen in the population. Discrimination is the ability of the model to identify actually which women will experience an event or develop breast cancer versus which women will not. So which 20 of the 100 will get breast cancer. The problem is that most of our breast cancer risk models have good calibration. They perform well at the population level, but they have poor discrimination. They don't tell us which women will be affected. So this is an example of one of the models. This model is developed by a group called the Breast Cancer Surveillance Consortium, and this is their risk calculator. The information in the middle of the screen, age, ethnicity, first-degree relatives with breast cancer, this is information that you input into the model. And then the model tells you your estimated risk for developing breast cancer. So for this patient, the estimated risk for developing invasive breast cancer over the next 5 years was 0.65%, so less than 1%. And they compare that to the average 5-year risk for a woman of the same age, race, and ethnicity. So an average risk woman has a 1% chance risk. So this woman actually is at below population risk. She is at very low risk for developing breast cancer. This is another example of a model. This is called the GALE model, or the Breast Cancer Risk Assessment Tool. This is widely available online. Again, you put in your information and it calculates your risk of developing breast cancer. And in this particular example, this patient's risk of developing breast cancer in the next 5 years is 1.3% compared to the average woman's risk of 1.1%. So this woman's at slightly elevated risk, but this level of risk does not does not qualify her, for example, talking about medications. So we do use these models in our clinic, and again, the iPad survey or the email survey, we collect the demographic information from you, all of the reproductive history information, your family history, and then these models give us an output. They tell us your 5-year breast cancer risk and your lifetime breast cancer risk. But the challenge here, and if you look at these numbers, is that these models don't all give the same number. And that's because the models use different inputs, they weight the inputs differently, and they were calibrated in different populations of women. So we use the models to identify broadly, again, who is at increased risk and who is not. But we really shouldn't focus specifically on these individual numbers, because these models are not perfect. They don't account for race and ethnicity. We know they don't perform as well in some racial groups, and the models also don't account for lifestyle factors. So our goal is really awareness, education, and to help women understand their options. And really it comes down to you as an individual. What risk seems too high or acceptable to you? Does 20% lifetime risk seem high to you? Does 30% seem high? And how are you perceiving this in the context of your other life experiences? Are you ready to make real lifestyle changes in diet and exercise, of course, with support that to reduce this risk? Excuse me. And also, how do you feel about prescription medications? We do have medications that reduce risk. Not all women are interested in medications. And then how do you feel about participating in clinical trials or research to help us understand more about this? What we do know is that if you are motivated to reduce your risk through lifestyle changes, that weight loss for any postmenopausal woman who is overweight reduces risk. Diet and exercise are important interventions and may attenuate risk independent of weight. And again, you heard more about that this morning. And realistic moderation of alcohol use is also likely to reduce breast cancer risk. So I want to highlight here that in the BPREP program that the P is really the key. The key is that we want this to be personalized. If we identify that a woman is at elevated risk, the goal is to match her unique risk profile with realistic, practical, and acceptable lifestyle changes and/or interventions, and the opportunity to participate in clinical trials to help that woman understand and manage her risk. So just to touch on a couple of factors in this list before we turn it over to Dr. Piskovsky: dense breasts and high-risk lesions. So there's a lot of questions out there about both of these factors. So what is breast density? Breast density is a measure of how your breasts look on mammogram. It's not how they feel when you have a breast exam, it's how they look on mammogram. And there are 4 categories of breast density ranging from fatty all the way to extremely dense. And you can see that most women in the population fall into the middle 2 categories: scattered fibroglandular density or heterogeneously dense. This accounts for about 80% of women who undergo mammographic screening. 10% have completely fatty breasts, and 10% have the extremely dense breasts. And we hear a lot about breast density and risk. And I just want to be clear that it's only for women in this extremely dense breast category, that 10% of women. These are the women whose breast cancer risk is impacted by their breast density. The women in the middle, the 2 groups in the middle that I shared with you before, those women are not at increased risk based on breast density. But women with extremely dense breasts are at increased risk when we compare them to women with fatty breasts. And that's how most of these studies are done. And we'll see they tell us that women with extremely dense breasts have a 3 to 5 times increased risk of breast cancer compared to women with fatty breasts. So what does that mean in absolute terms? So you don't want to know that you're 3 to 5 times more likely. You want to know what your absolute risk is. And so again, if we start with average risk, 12 out of 100 average risk women will get breast cancer. If we now take 100 women with extremely dense breasts, that number goes up to about 15 to 20%. So more women with extremely dense breasts, but it is not an absolute guarantee that just because you have extremely dense breasts that you will get breast cancer. And again, when we compare, it's increasing the numbers from about 12 to about 15 to 20 women out of 100. High-risk lesions. I am a surgeon, so I couldn't have this without talking about high-risk lesions. The most common high-risk lesions are atypical duct hyperplasia, atypical lobular hyperplasia, and lobular carcinoma in situ. These are high-risk lesions because they confer increased risk for a woman over her lifetime. And we know that from following large groups of women with these lesions and recording what happens to them. So this is data from the Mayo Clinic. They have a very large cohort of women with atypia that they follow and report their results. And women with atypical duct or lobular hyperplasia do have an increased lifetime risk of breast cancer, and that risk is about 1% per year. Women with lobular carcinoma in situ are also at increased future risk. These are data from Memorial Sloan Kettering Cancer Center, over 1,000 women that we followed with LCIS. Again, these women are at risk for getting breast cancer, and that risk is about 2% per year. Now, ADH is also something that we consider a high-risk lesion now, and that means that when ADH is diagnosed on core biopsy, that there is a likelihood that there could be an associated cancer there at that moment that the core biopsy needle just missed. So this is the diagnostic dilemma. You come in for your mammogram, there's calcifications. We take a core biopsy, which retrieves these very small pieces of tissue. Our pathologist then looks at these very small pieces of tissue under the microscope, and it can be hard to distinguish sometimes between a typical duct hyperplasia and the very earliest form of breast cancer, duct carcinoma in situ. So ADH on a core biopsy, right now we recommend complete excision to rule out cancer, and then we counsel about future risk. We are trying to work with our colleagues across the Mass General Brigham and MIT to see if we can use machine learning and artificial intelligence to better identify which women with a core biopsy diagnosis actually need excision and which women do not. And that work is ongoing, and hopefully we'll have something to share soon. So finally, what is the risk though? These are high-risk lesions. What kind of risk do they impart? Again, average risk, 12 out of 100 women. If you take 100 women with ADH or ALH, again, that risk goes up to about 15 to 20%. And if you take 100 women with lobular carcinoma in situ, that risk goes up to about 20 to 25%. So women are at increased risk, but it is risk that we are absolutely able to counsel women about and able to moderate. Again, further research that we're interested in is using genomics to try to understand which women in these groups will actually be the ones that develop breast cancer. We collect blood and tissue in the clinic, and many of you may have given us samples, so we thank you for that. And again, our goal is to try to provide better risk prediction. So for these high-risk lesions, first we discuss the surgical issues. Do any of them need excision or not? Then we discuss what is the risk and what are the options for reducing that risk. And Dr. Biskovsky is going to talk to you about medications. And then we discuss screening. Should we use additional screening in these cohorts? And again, the data are not so clear, so this really is a shared discussion, shared decision-making. What we do know is that chemoprevention does work. It reduces risk of breast cancer in patients with these high-risk lesions. This is again from the lobular carcinoma in situ cohort. Women who took chemoprevention in the red line, their 5-year rate of developing cancer was only 3% compared to 11% in the women that did not take chemoprevention. So the medications do work. The data on adding MRI screening for women with these high-risk lesions is unclear. These lesions are listed in the category of insufficient evidence to support for or against MRI screening. MRI is a good test, but it's not a perfect test. And so we do, again, try to individualize our recommendations for who should have MRI when we are counseling women about the risk associated with these lesions. And again, just in closing, I'm going to come back to BPREP. We really do try to provide personalized risk assessment and recommendations for all of our patients. We want to educate you and help you feel informed and engaged and proactive in what you can do about managing your breast cancer risk.